My name is Tessy Paul. I am from University of Virginia. I'm the clinical director for the ILD program there. I'll be talking about what's new in CTD-ILD. I have no relevant disclosures, and I will be talking about some off-label therapies, obviously, because that's all we have for CTD. So my goal today, or my objectives today, is to go over the CTDs associated with ILD, briefly talk about diagnostic evaluation as well as management, and then talk a little bit about the new classification, IPAF, or interstitial pneumonia with autoimmune features, and then talk a little bit about the new evidence in antifibrotic therapy and CTD. So as you heard from earlier talks, ILD is classified according to the etiology, whether it's related to exposure, whether it's idiopathic, and in this case, connective tissue disease related. So the CTDs associated, or that I'm going to talk about briefly, are lupus, systemic sclerosis, Sjogren's, rheumatoid arthritis, dermatomyositis, mixed connective tissue disease, and undifferentiated connective tissue diseases. And they tend to have very variable presentations with regards to degree of ILD, and as systemic sclerosis tend to have ILD as a very devastating complication, Sjogren's tend to have a better prognosis overall. So it's very variable between these diseases. So when you assess a patient with ILD, it's important that you consider CTD-ILD, especially in cases when you have young women under 50, and then it's important to do a detailed history with regards to symptoms, smoking status, exposure history, and family history. And there are some clues within the history that should suggest that there is an underlying connective tissue disease, whether it's rashes, Raynaud's, constitutional symptoms, arthralgia, sicca symptoms, dysphagia, and proximal muscle weakness. And same with physical exam findings. You should evaluate for rashes during exam, whether it's malar rash or a couple other things I'll talk about, mechanics hands, Cotron's papules, sclerodactyly, digital ulcers, oral ulcers, proximal muscle weakness. I always have patients watch my patients stand up after their visit to see if they have proximal muscle weakness. So these are some examples. On the left, you have mechanics hands, or dry cracked fingers with fissuring. On the right is Gottron sign, where you have erythema over the MCP and around the periungual area. And those can be seen with dermatomyositis. And here you can see sclerodactyly on the left with shiny thickening of the skin and can lead to contractures, and it's often seen with scleroderma. On the right, you again have Gottron signs, but with papules over the dorsum of the hand, over the MCP, and interphalangeal joints. And over the eye, you can see heliotrope rash that can be seen with dermatomyositis. Again, with diagnostic evaluation, which some of that you might have discussed earlier in the general ILD talk, important to do PFTs with 6-minute walk, where you might see restriction and diffusion impairment, and the CT or high-res CT should be done with ILD protocol, as again earlier discussed, with no contrast, supine-prone imaging. And with regards to histopathology, in general, biopsy is not recommended in patients with CTD-ILD, and I unfortunately do see some biopsies when I get patients referred from outside, and it gives me a chance to review them, but in general, they're not recommended. But in some cases, if you look at the position statement PFF put out recently, for example, you can consider in some of these patients if the radiologic or clinical courses are atypical. For example, if you have a patient with ILD and positive serologies, but maybe the CT suggests has perilymphatic nodules or air trapping that would suggest sarcoid or HB, and transbronchials are not diagnostic, maybe you would consider surgical. But so it was just in atypical cases. So with regards to considering CTD in your differential, all cases of NSIP, LIP, or any other ILD pattern with secondary histopathological features that might suggest CTD, such as extensive pleuritis, dense perivascular collagen, lymphoid aggregates with germinal center formation, and prominent plasmacytic infiltration, so it should clue you into thinking about an underlying CTD diagnosis. And with a lot of the diseases I mentioned earlier, many of them may present with just ILD as their initial, or in some cases, only a symptom of their CTD, so you might have a lung-dominant CTD. With regards to histopathological or HRCT findings, these are some of the patterns you might see, and you can see UIP most commonly seen with the idiopathic interstitial pneumonias, or IPAF, even though less common in CTDs in general, can commonly be seen in rheumatoid arthritis. So whenever you see UIP, it's important to not automatically think IPF and always rule out secondary etiologies. And otherwise, in general, the most common pattern is NSIP, and others to think about is TIP, although it's smoking-related, sometimes can be autoimmune disease-related, organizing pneumonia, LIP, DH, etc. So just to mention some of these patterns, this is NSIP, which is the most common pattern. You can see in this basilar slice diffuse ground glass with some subpleural sparing, traction bronchiectasis. And essentially, you will see if you do have pathology, you have uniform fibrosis and with no evidence of architectural distortion. You won't see honeycombing or fibroblastic foci. Organizing pneumonia is another common pattern. So you might see peribronchovascular, nodular, and ground glass changes. And on biopsy, if you do have it, you can see alveolar fibrin deposition. And often these patients, when they present, you might think of them as having bacterial pneumonia, and often are patients who don't respond to antibiotic therapies. LIP is a little bit more subtle finding. You can see subtle ground glass, and these arrows pointing to some cysts here, and on the right you can see lymphocytic infiltration with lymphocytes and plasma cells. And this can be seen with Sjogren's and more commonly than other ILDs. And lastly, just to mention UIP, you heard a lot with Dr. Raghu earlier, so I won't delve into this too much, but essentially you have subpleural basal predominance with honeycomb changes, which can be seen in pathology as well as subpleural with architectural distortion, and you can see a fibroblastic foci here. And in general, there shouldn't be a predominant ground glass pattern. So this is one interesting paper I just wanted to mention. So as I said, UIP can commonly be seen in CTD-ILD, especially with RA. So this is a paper that came out, I believe, last year with Jonathan Chung and colleagues from Chicago that looked at, is there anything specific with UIP and CTD that is different from IPF? So they picked these three things from, I believe, anecdotal reports. So anterior upper lobe sign, exuberant honeycombing, and straight edge sign, which I'll show you in a little bit. They already expected that patients will have, this will be associated with low sensitivity. So they had patients from their multi-ID discussion with IPF, about 133, with CTD-ILD UIP, that was about 63. And you can see it's very associated with very high specificity, although poor sensitivity, and having more than one sign was associated with high specificity for UIP-associated CTD-ILD. So these are the signs they mentioned. So this is the anterior upper lobe sign, where you have more fibrosis in the anterior part and relative sparing in the other parts, and of course with basilar involvement as well. And this is exuberant honeycombing, essentially means what it says, and about at least 70% of the fibrosis is honeycombing. And this is also the third one, and it's a very interesting appearing straight edge sign where you have a sharp craniocaudal demarcation as to the degree of fibrosis. You can see this sharp demarcation, and there's a lack of peripheral involvement beyond that. So in general, these showed more likely to be seen in CTD-UIP rather than IPAF UIP, but it was not associated with any mortality differences in multivariate regression. So it's also important, as I said, with CTD-ILD, other than looking at these parenchymal findings, that there are several other thoracic manifestations that can be seen in these patients, which again should clue you into the patient having an underlying CTD if it's not already diagnosed. So other than parenchymal changes, there could be vascular changes such as pulmonary hypertension, especially in people with systemic sclerosis and lupus, and these patients should be routinely screened. Other airway involvement such as bronchiectasis, especially in RA, obliterative bronchiolitis, and then DAH, especially in lupus patients, and then pleural disease and respiratory muscle impairment. So you can see these diseases can have multi-compartment involvement. In addition to that, you should also think about things like PE, especially in patients with lupus and scleroderma in terms of vascular involvement. You should also think about seeing esophageal dysfunction or esophageal dysmotility, or just seeing patulous esophagus on CTs in these patients. So in general, if you have a suspicion, you should go on with a serologic workup. Essentially, with history, you should exclude alternative etiologies, and I cannot stress enough the importance of having a good rheumatologist to work with you in these cases. So these should be multi-D discussions with your rheumatologist in terms of diagnosing and managing these patients. So this is just a list of useful antibodies in CTD-ILD evaluation. You can see several of these are associated with many of the CTDs. So again, this is not exhaustive. So at our center, we have an ILD panel. We tend to send with all our ILD patients with initial visits, and they include things like ANA, RF, CCP, SSA, SSB, dsDNA, and as well as myositis panel. And you can see there's certain things like SEL70 is really associated with scleroderma, or anti-Smith, and dsDNA with lupus, and then anti-MDA5 associated with clinical amyopathic dermatomyositis. And with these, I tend to send CK and aldolase in patients because otherwise you might miss myositis. And if your suspicion for myositis is there, you can also send things like a thigh MRI, EMG, and muscle biopsies and things like that. So with regards to management, again, it has to do with management of the underlying CTD. Again, your rheumatologist should be your friend with managing these patients. In general, the management is guided by immunomodulatory therapy, although we have very limited evidence for it. Otherwise, supplemental oxygen, again, this is extrapolated from the COPD population, pulmonary rehab, and in patients with progressive disease, consider lung transplantation early, and of course, palliative care becomes very important in some of these patients who are declining and are not transplant candidate. So I just put a list of some of the immunomodulatory therapies we use. Again, as I said, very limited evidence. Glucocorticoids are often used, and remember, in patients with scleroderma, high doses might precipitate scleroderma renal crisis. And most of the patients end up on Imuran or Cellcept or azathioprine and mycophenolate, and again, without much data, but I'll mention this a little bit more in a second, but often use rituxan or Cytoxan as rescue therapies in some of these patients. There's some literature or recommendations for tacrolimus or IVIG as an add-on for patients with anti-synthetase syndrome. There's minimal evidence, again, of things like anti-IL-6 antibodies, and there's some evidence in stem cells transplant for scleroderma. Again, I just put that here because for some reason, I get a lot of questions from patients about wanting stem cells transplant or stem cell therapy for ILD, and there's a small paper about the benefit of this. And unfortunately, people who had, this was myeloablative stem cell transplant, about, I think, 22% had relapse after. And so it's not something that's commonly done. So the only, or the few RCTs we do have has been in the scleroderma population. The only adequately powered two studies are the scleroderma lung 1 and 2. The first study looked at cyclophosphamide in these patients with regards to lung function and extrapulmonary manifestation, and they saw with 1 year of therapy improvement in FVC as well as some of the extrapulmonary symptoms. But unfortunately, the effects waned after, by 2 years. And unfortunately, of course, it was associated with significant toxicities as well. But scleroderma lung study 2, which came out in 2016, looked at mycophenolate and cyclophosphamide, and they saw that improved FVC in patients. And the thought was mycophenolate would fare better than cyclophosphamide, but in general, it was about the same, but mycophenolate was much better tolerated with less toxicity. So who should you be treating? So it's a tough question, and you should consider a lot of patient factors when you're deciding to treat, and whether they have active lung disease versus whether they have active extrapulmonary rheumatological disease. Again, your rheumatologist should be working on these patients with you. So in general, if you have symptomatic disease, you might consider treating them. Patients with minimal to no symptoms could be monitored clinically with PFTs. So factors to consider when you treat them are whether their disease is progressing, what is the severity of their lung disease as opposed to their underlying connective tissue disease, and also think about the likelihood of response. In general, even though we may offer therapy to all comers in terms of CT patterns, UIP pattern might be less responsive to immunomodulatory therapies, and NSIP and OP might respond better to glucocorticoids or immunosuppression. Also think about age. Are these therapies you want to start in patients who are 80, or as well as adherence? I have many patients who start therapies and never come back or don't take their labs or prophylaxis, so these are all things you should consider before starting therapy. So I want to spend the rest of the time and talking about some of these new things. So I'll talk a little bit about IPAF, or interstitial pneumonia with autoimmune features. So we have patients who fall in the completely idiopathic class or end of the spectrum, and people with full-fledged CTD-ILD. So there are people who have some of these autoimmune features, but doesn't have a characterizable connective tissue disease, and they fall in this IPAF group. Essentially, to fit IPAF criteria, you have to have ILD of some sort, whether by histology or CT, and then exclude alternative etiologies, including CTD. And then we have to meet at least 2 of 3 domains they suggested, and these are either clinical domain, which includes things like digital fishing, physical exam findings, essentially, pulmonary telangiectasias, Raynaud's, unexplained digital edema, and then some sort of serologic marker, whether it's high titer ANA, unless it's nucleolar or centromere pattern, and other things like CCPE, anti-Smith, and then myositis, tRNA synthetase markers. And then lastly is morphological domain. It's what you see on either CT or histopathology, if you have it, NSIP, OP, or LIP, for example. And they have a little bit of a vague group here as well in terms of other compartment involvement with pleural effusion or airway, unexplained airways disease. So you need two of these 3 to fit this criteria. And you can see UIP is not in here, but that doesn't exclude the IPAF diagnosis. You can still meet these 2 categories and have UIP and meet the criteria. But what do you do with these patients? It's not clear, unfortunately. So we have this classification from 2015, and it's still currently intended as a research classification. And there's been a lot of cohorts that came out one census has been published that looked at this population, and it's very, very heterogeneous in terms of their presentation and outcome. In general, NSIP tend to be the most common pattern. Raynaud's seem to be the most common clinical finding. But the idea is that maybe this criteria needs revision, and the natural history and prognosis remain unknown. And the idea is maybe they fit somewhere in between idiopathic interstitial pneumonia and CTD-ILDs. And it's not clear whether this is actually a distinct entity or an actual precursor to CTD-ILD. In 2 studies that I looked at, about 16% of patients went on to be diagnosed with connective tissue disease, ILD. So we don't know, do you treat these patients as connective tissue disease, ILD, or IIP? Especially if you have UIP, do you treat them with antifibrotics? And the answer is not clear, and I believe last year there was an abstract at ATS that looked at Imiran in these patients, and there was another study that looked at CellCept in these patients, and there is some benefit, but we need more data. So I would say you would have to approach these patients at a case-to-case basis. So there's a lot of new evidence that's all the rave right now in terms of antifibrotics. So if you look at clinicaltrials.gov, there's quite a bit of trials that's either completed or ongoing with regards to antifibrotics. In CTD-ILD, these 3 are done, and I'll talk a little bit about it. But there's nintedanib for other ILDs, scleroderma lung 3 that's still happening, which is mycophenolate and PreferNoDoane, and then PreferNoDoane and dermatomyositis and RA. So those are pending, and I'm sure there's more as we speak added to the site. So I think the most exciting out of these 3 probably is the one from the census group. So this looked at nintedanib for systemic sclerosis ILD, scleroderma ILD, and they used nintedanib 150 BID versus placebo for over 52 weeks. That's the same dose they used in IPAF. And these are patients with fibrotic ILD. They had to have at least 10% fibrosis on their CT. Their FVC were over 40, and DLCO over about 30 to 80 or so. And they, about half of them, I believe, 48% were on mycophenolate. So what they saw was that with patients who received nintedanib versus placebo, the overall FVC decline, absolute decline difference was about 41 mils. So they saw an overall benefit in patients who are on nintedanib with regards to lung function decline. So this actually led to an FDA approval of nintedanib for scleroderma ILD just in September of 2019. But in general, this is one trial. We don't know exactly, out of the patient, all the scleroderma ILD patients you might have, who do you start on nintedanib, or when to start on nintedanib is not clear. So you might want to discuss these with your patients and maybe consider them in all comers versus do you give them to patients who are declining despite immunomodulatory therapy, or you could even consider this in patients who cannot tolerate immunomodulatory therapy. So it's nice to have other options, I think. So this is the next trial I just want to mention, nintedanib and progressive fibrosing ILD from Kevin Flaherty and his group. So they looked at, the reason I wanted to mention it is because a good chunk of these patients had autoimmune ILD, so relevant to this talk in that way. So they looked at nintedanib 150 BID versus placebo. So these are patients who had fibrosis, again, at least 10%, and they also had to be progressing either by FVC decline or by, if less than the threshold they had, which was 10%, they had to have CT changes or symptomatic decline as well. And so they, interestingly, they excluded, of course, they had UIP patients, but they excluded patients with IPAF because we already know the benefit of nintedanib in these patients, and it wouldn't make some sense to put them on placebo. But they did enrich the population to have more UIP because it's felt that that population would progress more rapidly and therefore would have more of a benefit. So they looked at nintedanib in overall population as well as the UIP population as well. And compared to placebo, you can see there's a difference in overall decline in terms of FVC. And they didn't meet any of their secondary endpoint. So if nintedanib reduced FVC decline regardless of the fibrosis pattern. And as I said, about a quarter of these patients were autoimmune. I think about 20% were chronic HB. So again, do we start patients, progressive fibrosing patients on nintedanib? The answer is we still need more data, I would say. And this is not something that is FDA approved as of yet. So the last, or actually before, so it's interesting, these trials, again, they use the IPF data or IPF dosing, and the benefit they saw were fairly similar to the Impulsus trials that looked at nintedanib in UIP or IPF patients. So the last trial I just want to mention is PreferNoDoane in patients with unclassifiable progressive ILD. So this was a phase 2 trial, and this was a smaller population. The earlier were 600 and 500 patients. This had about 200 some for a shorter duration. So the reason I want to mention this in the CTD talk is because so about 12 to 14% had IPAF or whatever it's worth. So they labeled unclassified, or unclassified was defined as patients who couldn't have any other diagnosis by at least a moderate or high degree of confidence. And about 5% of the patients had concomitant mycophenolate use as well. So the population was fairly similar to the previous trials in terms of having the unclassified ILD diagnosis. They needed about 10% fibrosis on CT, and they also had a similar progression definition as well. So interestingly, they looked at home spirometry, or interestingly or unfortunately, they looked at home spirometry as their FVC or their primary endpoint. And as you can see, they did just one home spiro per day. And usually in PFT labs, we do multiple and take the best or see what needs to be thrown out. But to be less intrusive and improve patient compliance, they just did one spiro per day. And they didn't, I guess, they got very high. You can see this goes up to 36 and -4 in terms of the range of results they got. So it was very physiologically implausible and extreme values, and essentially they couldn't apply their statistical model and their primary endpoint. So, but they did look at, with regards to their secondary endpoints in terms of on-site FVC, which had, I believe, about 90 difference in terms of absolute difference, DLCO, 6-minute walk test, et cetera. They did show a benefit, so it turned to favor PreferNoDoane in the secondary outcome. So in general, this was a phase 2 trial. This suggests maybe with both of these drugs, earlier with nintedanib, the most common adverse effect was diarrhea. In this case, it was GI upset. And in general, it seems like another or future trials are warranted, and the safety is reasonable in terms of trying this in these patients, and maybe not with home spirometry for future studies. Again, both antifibrotics available have been tried in these patients with progressive fibrosing disease. So some take-home points from the talk. So ILD is a major contributor to morbidity and mortality in these patients with underlying connective tissue disease. Diagnostic and management decisions require a multidisciplinary approach, and many centers have combined rheumatology ILD clinics that are helpful, and we're trying to start one at our program currently as well. And current therapies, as I said, have very limited evidence and is based mainly on immunosuppression. And there's new evidence available for antifibrotic therapies in terms of options, especially in scleroderma and potentially in some of the other autoimmune or IPAF cases, but certainly additional trials are necessary. Thank you. I think I'll take questions with the panel.